Thank you, Brian, and thank you to the organizers for inviting me here. Always a very meaningful conference to be at, and like Brian said, certainly in person is very meaningful, and I always try to be here if I can. I see a lot of new faces this year, so welcome to this much larger conference, and also hello again to those that I've seen in previous years. So as Brian said, I represent the U.S. Centers for Disease Control and Prevention. For those who are not aware, that is our nation's health protection agency. And that's just a shot from our website describing the mission of CDC. We are under the Department of Health and Human Services, and our main goal is to protect America from health threats and also safety and security threats. And we do that by conducting critical science and providing health information to the best of our ability. See a question mark there after CDC organization. It's definitely a time of transitions, not only within our particular division, but within CDC as a whole. And we're not sure exactly how the various puzzle pieces are going to fit together going forward. Lots of things are going on much higher than my personal level, but we hope that we are able to continue our Prion work in the coming years. We have a very small group. It became even smaller this year. The first picture there you'll recognize. I'm sure you've seen him around this weekend. That's Dr. Schoenberger. We also have Marissa Person, Dana Haberling, and Joe Abrams working with prion disease surveillance as well. And surveillance is our primary mission, surveillance for human prion diseases. And I think Debbie Yob described the importance of surveillance last night in her talk. But essentially, this is monitoring disease in the population. And we do that by estimating prion disease rates, looking for changes in trends over time, and investigating cases of interest. And I'll talk a little more about what a case of interest is later. How do we conduct surveillance for these diseases? Well, the primary way, our main way of keeping track of what's going on in the country each year is our close collaboration with the National Prion Disease Pathology Surveillance Center and the National Center for Health Statistics. And so the National Center for Health Statistics is able to provide us with death certificate data for the entire country. And so if you die in this country, you receive a death certificate. There's a code or codes indicated on the death certificate with the cause of death. And I know not everyone in this room has had good experiences with that. The cause of death may not be CJD on the death certificate. And I'll talk about that a little bit as well later. But these data are routinely obtained and cost effective. They're a good source of information because, unfortunately, these diseases are always fatal. And we do look for various different things that could indicate CJD beyond a simple code. So we're able to look at the literal text on the death certificate. If it says CJD or prion disease or even mad cow or any number of misspellings of Creutzfeldt or Jakob, we pick that up. And so we have a pretty good system in place to get that information from the death certificate, but it's certainly not perfect. We combine these data with data from the National Prion Disease Pathology Surveillance Center. So anyone that's had a specimen tested at the center, that data is shared with us. And we use that to combine it with the death certificate data to get a good picture of what's going on in the country. And just to give you an idea of the numbers we're talking about, over the 20-year period, 2003 to 2022, 9,140 cases in our data. That comes out to 1.2 cases per million population per year, age adjusted, and slightly higher among males, 1.3 versus 1.2 among females. Of course, this is a disease of the older population. So when you break that down, just looking at those 65 and older, that jumps up to 6.2 cases per million. Our most recent year of data that we've more or less finalized was 2022. We're looking at 2023 now. 2022 is more or less complete. I have an asterisk there just because we're not quite done. But our belief is we're right around 631 cases in the country. That comes out to 1.4 per million population, so a little bit higher. And you've heard talk of this other statistic a little bit, I think, over the past couple days. But if you look at all the deaths in the country in the year, and then look at all those that died of prion disease, it's another way of looking at it. It actually comes out to one prion disease death for approximately every 6,000 deaths overall in the United States. And again, there's other ways of looking at that as well. If you look at 2022 alone, the most recent year, again, of full data, it's closer to 1 in 5,000. That 1 in 6,000 over that 20-year period combined. So certainly the disease does not seem quite as rare looking at it through that perspective. This percentage, 83%, actually more than that, of matches between the death certificate data and the Prion Center data, I think just really goes to show how great of a job the National Prion Disease Pathology Surveillance Center is doing in terms of people being aware of their services and taking advantage of their expertise. And so most cases in that death certificate data have had a specimen submitted to the Prion Center. Dr. Appleby mentioned earlier that sometimes that means that it's not a true case. In fact, looking at 2022, we removed 8 cases from our tallies because the Prion Center did an autopsy and ruled out prion disease, even though they were in the death certificate data as having prion disease. Meanwhile, we added 46 cases that were autopsy confirmed at the Prion Center, but not in the death certificate data. And those numbers are pretty consistent with previous years where we've done this matching. I was hoping that that 40-something number was going to start going down as RT-QuIC became more prevalent. But it's been fairly consistent that we're adding a large chunk of cases each year to the death certificate data. This is just numbers going from 2003 to 2022. You can see that the numbers are going up. What does that mean? Well, we have 3 main explanations for why we're seeing this. Number one, we have an aging population in this country, and of course we know that these diseases are primarily in the older population. So more older people means more cases of CJD being diagnosed. Number 2, more awareness of these diseases. Fortunately, there's still a long way to go, but in general, providers, state health departments, more awareness of these diseases and more actions being taken to appropriately diagnose them. And finally, there's better diagnostic tools out there now. RT-QuIC, as you've all heard, has been a game changer in terms of diagnosing patients while they're still alive. And MRI in the hands of someone that knows what they're doing can also be extremely accurate in diagnosing these diseases. So we've seen improvements there, and I think all 3 of these things have contributed to the rising numbers in this country. Like I said, RT-QuIC strongly indicates prion disease when positive. One limitation, as we look at the Prion Center data, is if an autopsy is not performed, we may not have a date of death for that particular individual. And so we've looked at this and found that there may be 20% more cases per year if you look at the RT-QuIC data coming out of the Prion Center that we don't have assigned to any particular year. And so that 1.3, 1.4 statistic could be 1.5, 1.6 per year. We don't think it's going to be drastic and go up to 4 or 5% per million per year. But certainly that 1.3, 1.4 may be a bit of an underestimate. I mentioned earlier cases of interest. Well, one big group that is of high interest to us are those cases that we designate as young cases, and we define that as less than 30 years of age. We pay certain attention to these cases because most cases in this age group have something unique about them, a genetic mutation or other risk factor, for example, cadaveric human growth hormone in their past or variant CJD. To give you an example of how rare these cases are, 20 cases in the 20-year period, 2003 to 2023, that comes out to about 1 case per year. And of course, that's not always true. We had 3 cases one year, and of course, there's been years where we've had 0 cases. But only 8 of those were sporadic, and the remaining 12 were various familial diagnoses, a couple variant CJD, and one iatrogenic linked to dura mater. And that snapshot there is just a case report of one of the most recent young cases. This young person was in their early 20s, had an unusually long incubation period of more than 2 years. And of course, we looked into this case and wanted to publish it. Of course, the Prion Center were authors on that as well, and wanted to get out the word that, these cases do still happen in these young age groups. They may live longer, and we want to look at possible risk factors to make sure we know what's going on in these cases. Autopsy, still very important. RT-QuIC is great, but we still measure it against the gold standard of brain tissue analyses. Autopsy is going to be our best bet as a sentinel for unique and possibly emerging prion disease cases. You've heard talk of chronic wasting disease. How are we going to know if that's transmitting to humans? Well, one of the main ways is if we see unique neuropathology. I mentioned that we do surveillance through death certificate data from NCHS, through the specimen data from the National Prion Center. We also rely on public health departments and medical personnel, family members, the public, and the media. So all these sources come together for our surveillance. We make no claims that we capture every single prion disease case in this country, but we do feel like we capture the vast majority. And we do include all verified cases in our prion disease surveillance. I know some of you, again, have been through these situations where the cause of death has not indicated prion disease for your loved ones. Most states do have a process where you can change the death certificate. Different processes from state to state, but do feel assured that if they had a specimen through the Prion Center, we haven't missed that case. We are aware of your loved one. These diseases are reportable to some degree in most states. The bottom line is if the case is misdiagnosed, we're still not going to hear about it. There's no cure for misdiagnosis, unfortunately. We did provide a statement to the Council of State and Territorial Epidemiologists outlining specific actions that could be taken to meet surveillance goals. And sometimes making a disease reportable in a state can help accomplish those goals and make it easier for them to collect medical records or be aware of cases within their state. And we do provide funding to strategic states for enhanced surveillance. So a big part of our funding that we receive from the federal government goes out the door to the Prion Center. A smaller percentage goes to specific states. And some of you this weekend have spoken with Rachel Straver, who's here from Texas. Texas is an example of a state we fund because they've had chronic wasting disease, they've had BSC, they've had variant CJD, they've had a little bit of everything, including the high population. And so we give them funding to keep track of what's going on in their particular state because they're more attuned to what's going on the state level than we can be from where we are. I'll talk a little bit about clusters. We look into these situations. They are reported to us fairly often. This one is probably the most recent in Oregon. You can see the headline there from the Los Angeles Times that they were investigating a rare brain disease, blamed for 2 deaths. For some reason, they have a picture of 2 deer. And that gives an example of what happens with these clusters. Deer had nothing to do with this cluster, at least as far as we know, but yet that's the picture they ran with. So when we look into these clusters, they inevitably dissolve when we take a closer look. And there's a variety of reasons for that. One is some of the cases are misdiagnosed in the first place. What starts out as 4 cases of prion disease ends up being 2 because 2 are Alzheimer's or something else. The cases may have recently moved into this small area. They might have genetic forms of prion disease that explain why they were diagnosed. And finally, the number may actually be what's within the expected range. And that was kind of what happened in Oregon. If you find some cases and draw a circle around it, you might say, oh, look at this. But cases will occur in a certain area by chance alone. It's not unexpected. We see this happen, and then they'll go 5 years without another case, and things tend to balance out over time. But state and local health departments, of course, are valuable partners as we look into this. We worked very closely with Oregon state and local health departments as they tried to gather more information about the cases in this small town in Oregon that were reported, and we wanted, of course, to make sure there were no commonalities, no risk factors that could have contributed to those illnesses. I'll talk briefly about acquired prion diseases that we also keep an eye on. This is an article that came out just last month looking at human growth hormone. This is the most recent case, incubation period approaching 50 years. So quite unbelievable that an exposure that long ago can continue to cause a problem so much later. So we found that of interest and wrote that up again in collaboration with the Prion Center and the providers in that particular case. So this keeps us busy on a fairly regular basis beyond our regular surveillance because things come up. I mentioned the cluster in Oregon, but there was also a case of probable CJD diagnosed with RT-QuIC in a person with a history of cornea transplant. And of course, corneas have been implicated in a couple cases of iatrogenic CJD. So we were concerned, but in collaboration with the state, we looked into the donor's history and found no evidence of undiagnosed neurodegenerative disease and felt comfortable that it was just a coincidental case of sporadic CJD in someone that happened to have had a cornea transplant a year before. We had a case identified by Marissa Person in the death certificate data where they had a code for CJD, but also for hemophilia. And why are we concerned about that? Well, that could indicate blood transmission of CJD because these patients with hemophilia may receive lots of blood transfusions in their lifetime. Turned out that was a miscode. The person did not have hemophilia, but another blood disorder that did not require multiple blood transfusions. We would not have known that, of course, without taking a closer look. So these are the kinds of things that we certainly pay attention to. And of course, the most famous acquired prion disease, variant CJD, that Dr. Appleby touched on, 233 cases worldwide, no cases, and I think this is very important and quite and something I'd like to emphasize, no cases since 2021 worldwide. So seems to be on the way out, if not out. We are still monitoring for cases of variant CJD. Of course, this is what's been linked to mad cow disease. But the good news is we seem to be nearing the end of that outbreak. You cannot diagnose, you cannot donate, rather, human cells, tissue, things like cornea, skin, bone, with the diagnosis of prion disease or a history in your family, or if you spend a certain amount of time in the UK and Europe. But organ donation is not regulated, and so there's really a risk-benefit analysis that's performed to see whether those organs will be chosen to be used or not. When it comes to blood, variant CJD has been transmitted through blood. It was reported in a few patients in the UK. Interestingly, the donors were asymptomatic at the time that they donated the blood. So there are still some concerns about additional secondary spread. However, the guidance was updated in this country in 2022 that does now allow people that spent time in the UK and Europe to donate blood. So that was a big change at the time because they were deferred for decades from donating. So if you are in that group, certainly look into that change if you're interested in donating. However, people are still ineligible from donating if they've been diagnosed with prion disease, if they've had receipt of human growth hormone or dura mater. This article was recently published last year by Dr. Schoenberger and Lauren Crowder with the Red Cross. The conclusion there was that CJD is most likely not transfusion transmissible. This is in agreement with other studies that were done in Europe. If it is a risk, it's extremely small, and it remains theoretical, in contrast with variant CJD. been talking about this for 25 years, but fear still exists out there among funeral homes, unfortunately, about patients or decedents with prion disease. Embalming bodies who have been autopsied can be safely performed, but we cannot force that to happen. Education is extremely important. We certainly appreciate the efforts of the CJD Foundation in that regard. And we do have information on our website that specifies there's really no special requirements for patients with CJD. You can bury bodies in closed caskets. It's not going to cause risk to environmental contamination, and cremated remains can be considered sterile. I'll talk briefly about chronic wasting disease because that is a priority for us. It continues to be found in new areas of the country. Most recently found in my home state of Georgia is the 36th state where it's been detected. Also in a handful of European countries as well. Highly transmissible. You can see the red there, all the places in this country where it's been found. Originally identified in Colorado and Wyoming, but being found, like I said, in more and more places. The Center for Infectious Disease Research and Policy in Minnesota convened a group of international experts. They were nice enough to include me as well, to look at what we can do in anticipation of potential chronic wasting disease spillover to humans. And they came out with a report that's available online and several conclusions, one of which was to promote human prion disease surveillance, which I certainly think is important to try to detect CWD spillover in humans if at all possible. We don't have any evidence at this time that the disease has transmitted to people. However, it keeps being found in more areas. That means more opportunities for exposure. That's a concern. We have the history of mad cow disease, BSE, transmitting to humans as variant CJD. So we know this can happen with another animal prion disease. And finally, some animal studies have actually suggested the potential for this to happen, as well as the fact that multiple strains may exist with different transmission properties. So continued vigilance is certainly essential to see if transmission can occur. And we have several studies going on to try to find out what exactly is going on. So we're working closely with the state health departments in Colorado, Wyoming, and Wisconsin to get some answers. In Colorado and Wyoming, we look at people that obtained hunting licenses to hunt in those states and looking at what they're dying of. Are they dying of prion disease at a higher rate than we'd expect for the general population? Fortunately, so far, we have not found that. In Wisconsin, they actually contact hunters that had an animal tested, and if it's positive, they ask if they've consumed the animal. If that answer is yes, we keep track of that person. We look for their name in the Prion Center data. We look at their name in state mortality data to see if they are dying of prion disease. So far, fortunately, we have not found any cases of prion disease in that group. We hope that remains the case because a prion disease diagnosis among someone that knowingly consumed venison from a CWD positive deer, of course, would be a very big red flag. Briefly, COVID-19, some people have had concerns over the last couple years about whether that could lead to prion disease due to some reports on the internet and so on. The bottom line is most older people in this country have received at least one vaccine shot. And some of them, by chance alone, are unfortunately going to come down with prion disease. That's a fact. We don't believe that there's a connection. Prion diseases are characterized by long incubation periods, typically years. So people that received a shot and then a week later were diagnosed with prion disease, we don't see a biological mechanism where that makes sense. According to Dr. Appleby in the Prion Center, they have not identified any unique neuropathological features among cases that were reported to them as being possibly vaccine-related. Obviously, that's important. And the numbers from 2019, before the pandemic, to 2021 were all very consistent, not indicating any kind of sudden blip due to the disease itself or the vaccine. Just final thoughts. These diseases are unique, and that leads to diagnostic and public health challenges. We try to approach those challenges by conducting surveillance using various methods. We try to investigate cases of interest, including young cases, potential acquired cases, reported clusters, and we try to provide the best advice possible on prion disease-related issues. We collaborate with medical and public health personnel, the Prion Center, the CJD Foundation. We find this essential to doing our job and hope that it can continue into the future. And we certainly appreciate the diagnostic test enhancements that have happened in recent years, like RT-Quick, that certainly will benefit our surveillance efforts. These are some resources I'm sure you're all aware of, and acknowledging, of course, the people I work with, as well as the Foundation, the Prion Center, and state and local public health. Thank you very much, and happy to answer any questions.